We know that the renal unit, which is responsible for the renal function, it is called the nephron. Nephron is supplied by an afferent arteriole and efferent arteriole. This afferent, which is carrying all body metabolites to be filtered at the glomerulus, which is taking all filtered blood, then it go back to the heart. This is mechanism is called the glomerular filtration. Here you will have formation of this nephron, which is formed of, you see, this is the glomerulus, which has afferent and efferent arteriole. Then you have the proximal convoluted tubule, and this is called lobe of Henle. Then after it, we have distal convoluted tubule, and after it, we have the collecting tubules. This is afferent, this is efferent, and this is the glomerulus. Proximal convoluted tubule, this is descending limb of lobe of Henle, and this is the ascending limb of lobe of Henle. This is also called a distal convoluted tubule, and this is called the collecting tubule or collecting duct. We know also that distribution of cardiac output is collected into this word, LKM. Liver is taking about 25 of the cardiac output, while kidney is taking about 20% of cardiac output, and muscles is taking about 15% of cardiac output. These are the first three organs to take part, huge bulk from the cardiac output. After it, we have control of blood flow through the kidney, which is usually controlled by the myogenic control of the arteriole itself, which is coming within the afferent. This is to keep the normal autoregulatory mechanism of the kidney just between these two scales of pressure, between 80 to 180 millimeter mercury. Here we have known what is called the glomerular filtration function. How we can calculate the glomerular filtration rate. I will give you the equation for this, which is GFR equal V multiplied by U, which is over B. What is V? V is the urine volume, while U is concentration of solute in the urine. Then B is concentration of solute within the plasma. So V is volume, while U and B are concentrations. This concentration of solute in urine, concentration of solute in plasma. Normal GFR is 125 milliliter per minute. Normal GFR is 125 milliliter per minute. Then you have another definition called renal clearance. What is the difference between renal clearance and glomerular filtration? Glomerular filtration rate is the total volume of plasma which is leaving the capillaries to enter the glomerulus itself. But what about the renal clearance? This renal clearance is the volume of plasma which is removed from a substance per minute in the kidney. Again, glomerular filtration rate is the total volume of plasma which is passing from the capillaries to enter the kidney per minute, to enter here into this Bowman capsule. While the renal clearance is the volume of plasma which is cleared from substance by the kidney in minutes. And regarding renal clearance, we usually use some substance to measure the GFR, glomerular filtration rate. We have three important substances to measure the GFR. First one is called Inulin. Second one is create. Third one is glucose. Here I will put some criteria to make an ideal substance for GFR. First one, this substance should be inert, not active, not to cause any chemical reaction. This substance should be freely filtered, completely filtered through the foaming capsule. After it should be not reabsorbed and not secreted. To measure the GFR, this substance should not reabsorb it, means that it is not reduced in volume. And not secreted or excreted means that also it will not increase in volume. So the substance should be inert, freely filtered, not reabsorbed, and not secreted. Secreted means excreted. This substance is used to measure the GFR. Which substance is best for this? It is called inulin. This substance, which is best for this. Inert, freely filtered, not reabsorbed, not secreted, and also its plasma concentration is constant during the urine collection. This substance is called inulin. Why creatinine and glucose are not used? Creatinine is partially secreted or excreted, while glucose is partially reabsorbed. This substance can be used to measure the GFR through equation, which is V multiplied by U over P. Here, the best for this is inulin. We don't use creatinine or glucose. Creatinine, which is partially secreted or excreted, while glucose is partially reabsorbed. Now we are going to assess the tubular function. Not insulin, it is inulin, not insulin. Yes, option and inulin and the create. You will go for inulin. The best. The best is inulin. Creatinine, I said, it is partially excreted, while glucose is partially reabsorbed. Then now, we will discuss the tubular function of each tubule. First one, we have a very important system to be here. I will try to make it simple by the next slide. This one, as you see, this is the same picture of the nephron. We have here the afferent and efferent which are entering the glomerulus. This is called a proximal convoluted tubule. This is the ascending limb of loop of Henle. Ascending limb of loop is called a distal convoluted tubule, and this ascending limb, and this is thin ascending limb. Ascending limb loop of Henle is divided into two segments: thin ascending and the thick ascending. Let's discuss each one of them. We have multiple functions in the proximal convoluted tubule. This one, proximal convoluted tubule, is responsible for reabsorption and co-transport of some substance with sodium, because sodium is measured to be absorbed here by about 20 to 25%. This is the first one. Second one, some factors are reabsorbed with sodium. They are like glucose, amino acid, acetoacetate, then phosphate. Added to them, plus 2/3 of substance related to the proximal convoluted tubule. Again, reabsorption of sodium by about 20 to 25%. This sodium is absorbed by active transport, while here some substances are co-transported with this sodium. They are glucose, amino acid, acetoacetate, phosphate, and you have also urea, plus 2/3 of water is reabsorbed into the proximal convoluted tubule. This is regarding the proximal convoluted tubule. Usually to know that we have surrounding this loop of Henle a blood vessels. These are responsible for what's called current exchange mechanism. What is this counter current exchanger and the multiplier? Counter current exchanger is between the loop of Henle and the vasa recta. Counter current multiplier is just to multiplicate the osmolarity of the medulla through loop of Henle. So multiplier is through loop of Henle, while exchanger is between vasa recta and loop of Henle to exchange some substance in between them. Then you have a very important substance to assess the effective renal plasma flow. This substance is called PEH. It is a para-amino hippuric acid. This para-amino hippuric acid is a solute which is completely cleared with a single passage from the kidney. And this can be to assess the effective renal plasma flow. This is very important. Here, the tricks in each question. It came in exam GFR, which substance is the best? Inulin. Effective renal plasma flow, which substance is the best? It is a solute called para-amino hippuric acid. Keep this two names as your name. They are very important. Then let's continue. We have discussed this proximal convoluted tubule. Let's go downward with the descending limb of loop of Henle. This descending limb of loop of Henle, some principles about loop of Henle. First one, it is formed of descending and ascending. And this ascending is formed of thin part and thick part. Loop of Henle usually has approximately 60 liters of water containing about 9,000 millimole of sodium pass over it daily. You should know about 60 liters of water containing about 9,000 of milliliter sodium are passing through loop of Henle. We have descending limb of loop of Henle. This descending limb is permeable only to water. Here, it is permeable to water. So here, I will not absorb anything except water. I am absorbing water and the solutes are increasing in osmolarity inside because I am leaving solutes inside and I am absorbing water. This is responsible for increasing the medullary interstitium from 300 above to 1,200 below. Again, here, the descending limb of loop of Henle, which is a part of counter current multiplier mechanism. This is responsible for increasing the medullary osmolarity because here you should know that we have the proximal convoluted tubule, distal convoluted tubule are found within the cortex, while the descending loop of Henle, ascending loop of Henle, and some part of the collecting tubule are found in the medulla. Here is the medulla and here is the cortex. Increasing the medullary interstitium osmolarity is by passing of water through the descending limb of Henle from 300 to 1,200 below. Then, what is the function of this ascending limb of loop of Henle? You have thin ascending and thick ascending. All of this are not permeable to water. So the descending is permeable to water, the ascending is not permeable to water. Here, I will reabsorb solutes. This thin ascending limb of Henle is responsible for solutes, sodium, and chloride. While this thick ascending loop of Henle is responsible for sodium, potassium, and 2 chloride. Keep this. Here, this tubular function is very important. Loop of Henle, descending limb of loop of Henle, is responsible for reabsorption of water. And here, it is also responsible for increasing the medullary interstitial osmolarity from 300 to 1,200. Then, the ascending limb of loop of Henle. You have thin ascending and thick ascending. This thin ascending is responsible for reabsorption of sodium and chloride, while the thick ascending is responsible for sodium, potassium, and 2 chloride. This is the function of loop of Henle. Then here, once here you are reabsorbing solutes, then you are reducing osmolarity. Osmolarity is reducing. Why? Because you are not permeable to water. You are living water. So here, you will reduce osmolarity from 1,000 to 200 until you reach in the proximal convoluted tubule by 100. Here, you will start to add some solutes and urea to increase the osmolarity into 300. So you will start by 300 to end by 300 osmolarity, passing through all of this course of loop of Henle. So here, this is the start, this is the end of osmolarity. Now, let's give some concepts about the difference between acute renal failure and pre-renal failure. As you see into this table, you have here pre-renal and renal. How will you differentiate between pre-renal and renal? You will differentiate by if you have intrinsic renal disorder, so you will lose sodium and urea. So here, once you have increased the urinary sodium or increased the fractional sodium excretion or increased the urinary urea or increased the fractional urea excretion, so you are talking about intrinsic renal disorder or acute tubular necrosis. Here, all of this, just to keep the first three, are increased with acute tubular necrosis, while all will be reduced. Fractional sodium, fractional urea, and increase the urinary sodium itself. Increase the urinary sodium itself, not this like the third one. So are the first three, add to them, increase the urinary sodium. So we have a first three which are increased in a case of intrinsic renal disorder. Increase the urinary sodium, increase the fractional sodium excretion, and increase the fractional urea excretion. Otherwise, all are reduced in intrinsic renal disorder. Just to keep this. No need to know numbers except that you will have increased the urinary sodium, by about 10. But here, you will have reduced urinary sodium by less than 20. This is the only number you should keep. Then let's go back to the diuretics. Because we have 5 diuretics acting on 5 channels at 5 sites of nephrons. Let's start by the proximal convoluted tubule. The diuretic is called acetazolamide. So acetazolamide, which is carbonic anhydrase inhibitor acting in proximal convoluted tubule. This is the first one. Second one, in the ascending loop of Henle. But here, it will act over this. No, excuse me. This is the second one, which is the descending loop of Henle. This is the mannitol. And this mannitol is an osmotic diuretic. Third one is called the loop diuretic. What is loop diuretic? Loop diuretic is the furosemide. In some books, Lasix. Furosemide is acting on the thick ascending loop of Henle by acting into sodium, potassium to chloride channel. While the distal convoluted tubule, and its junction with the collecting tubule. This is the site of action of the aldosterone. It will act in potassium and hydrogen channel. It will act on potassium and hydrogen channel. Then you have last one, which is EDH. EDH will act on the collecting tubule by insertion of what's called aquaporine 2 channel. What is this EDH, by the way? It is antidiuretic hormone. It is vasopressin, which is released from the hypothalamus through the pituitary stalk or pituitary neurological junction between hypothalamic hypophyseal junction in order to be stored within the posterior pituitary. This is called antidiuretic hormone or vasopressin. This is act on insertion of aquaporine 2 channels. Aquaporine 2 channels to help reabsorption and retaining of water to increase the urine osmolarity by acting onto sodium and potassium hydrogen channels. This is very important. Again, as you see into this picture, this is very important. First site for action of acetazolamide, it is the proximal convoluted tubule, and it is for carbonic anhydrase enzyme. Second one is the mannitol, which is osmotic diuretic, just here on the thin descending loop of Henle. This is just to reabsorb water. Then you have the thick ascending loop of Henle, site of loop diuretic, which is called furosemide or Lasix. It will act into sodium, potassium, and the 2-chloride channel. Then you have the distal convoluted tubule. Distal convoluted tubule, this is the site for also thiazide diuretic. This is the site also for thiazide diuretic. It will act, this thiazide diuretic, into sodium and chloride channel. Sodium and chloride channel. Then you have the junction between the distal convoluted tubule and the collecting tubule. This is the site for aldosterone. And this aldosterone will act into hydrogen potassium channel. Then you have the antidiuretic hormone, which will act into this collecting duct by insertion of aquaporine 2 channels into the potassium channels, into the sodium channels. Here we have collected this furosemide, thiazide, and spironolactone. Remaining for them, this is acetazolamide, mannitol, and the antidiuretic hormone. There are 6 drugs or 6 hormones acting into this loop of Henle. You should keep. What is this single number? It is here. Up to 25 of filtered sodium can be filtered using Lasix or furosemide in the thick ascending limb of Henle. This is about 25. And see, the proximal convoluted tubule also I have 25 of the sodium. So here, sodium 25 in